Oncology Club for this invitation. Uh, I will be discussing de-escalation in head neck radiotherapy and personalizing dose without compromising care. For those of us who work in head and neck cancers, we know that the head and neck region is full of structures which are very, very sensitive to radiation. And the dose received by these structures impact various aspects of the patient's quality of life. It's not just the saliva, it's the teeth, it's the ability to swallow, it may be the ability to eat out. In South Asia, it's important for us to be able to have spicy food. It may be employability or even emotional health. And therefore, restricting the dose to all these normal structures is very, very important. Where are we today with photon-based techniques? What you see on this side, the table, is the studies, various randomized studies that have been published in the field of IMRT. And we see that in the study arm, not the control arm, but in the intervention arm, about 30 to 40% of patients continue to have the toxicity that was being that we were trying to protect in that study. So for example, in the dysphagia optimization study by Chris Nutting, 50% of patients still had an impairment of their swallowing function 1 year after treatment. Similarly, in nasopharyngeal cancer, we see that at 5 years with modern radiation techniques, this is a study that was published in 2020, a review, about 50% of patients have grade 3 toxicities or more. I was just discussing with Dr. Thoria here that, I realized that my talk was overlapping with hers, and I will only skim through the fact that in oropharyngeal cancer, there is an enormous effort to de-escalate treatment. And that effort is because in P16 positive tumors, especially in P16 and HPV positive tumors, the outcomes are better. But when we talk about de-escalation in the context of HPV positive tumors, we have to understand that there is a lot of caution that has to be paid. In the sense that if we see so many interventions, when we look at, for example, the substitution of cisplatin with cetuximab, we have poorer survivals and higher locoregional relapse. When we look at the orator trials where we have tried to substitute radiation by surgery, what do we find? We find that actually patients have, if we see the graphs there, the swallowing outcomes are better with radiation. So whatever we set out to achieve, better quality of life, has not really been achieved. And an important point of the orator trial is that the pain scores and the tooth-related activity was actually worse in the surgery arm. Similarly, the orator 2 trials, as we know, had to be stopped because there was a higher incidence of grade 5 toxicity and many more patients died after surgery than was acceptable. So when we talk about reducing doses in the context of head and neck cancers, we have to be very, very cautious. There have been 2 studies where there is some evidence of benefit, but that benefit is restricted to a very small group of patients. Patients who do not have hypoxia and who are node negative. And similarly, in the Mayo trial, adjuvant treatment in patients who were N1 or N0. So while we would like to de-escalate, I think there has to be a lot of caution. And in contrast, when we discuss about de-escalation of doses, after all, that is what we want to do with de-escalating the doses. We want to preserve the quality of life of patients by reducing the dose being received by the normal structures. In that context, it becomes very, very important to actually discuss proton therapy, which is not being discussed enough in the head neck scenario. So this is a proton therapy plan on your left, an IMRT plan in the middle, and a dose differential, the radiation dose that a patient does not receive by receiving proton therapy. And as you can see, the reduction in the doses is very, very significant, ranging from between 40 to 70% to various structures such as the larynx and the spared constrictors. For the non-radiation oncologists in the audience, that happens because protons do not travel beyond a certain point, and therefore the sparing of normal structures is much more effective. I will first discuss proton therapy in nasopharyngeal cancers. We do know, of course, that in nasopharyngeal cancer, we have been able to de-escalate the volumes. So patients with N0 disease do not need treatment in the lower neck. We can cut down or identify patients in whom we need not treat the 1B lymph node. And similarly, patients who have undergone chemotherapy, we can reduce the volumes. So yes, definitely de-escalation has been possible in nasopharyngeal cancer, but it can be improved by proton therapy. So I will like to focus on two studies. One is Anna Lee's systematic review, which looked at 4 studies comparing IMPT with IMRT. And what we find is that there is a significant reduction, 65% versus 20% in the feeding tube rates, and much lower grade 3 toxicity in patients receiving proton, 76 versus 11%. Another very important study is the study from Taiwan, in which this is a propensity match studies about 200 plus patients. Again, gastrostomy tube reduction, insertion is much less in patients undergoing proton therapy, and something that you will see recurring in various studies, the outcomes are better. So the outcomes of patients undergoing proton therapy for nasopharyngeal cancer are significantly better. As you can see, the p-value is 0.001 in this graph. And for that, which is the disease-free, so disease recurrence, again, it's nearing on to significance at 0.71. So this is a big advantage of proton therapy in nasopharyngeal cancer. Again, a dose differential, proton on the top, IMRT at the bottom, and the extra dose that a patient does not receive by receiving proton therapy. What is the advantage in terms of the real numbers is this comparison that I will show you of this 41-year-old man in which we were able to reduce, this is a patient treated at the proton center and doing well about 4 years after treatment. Temporal lobe doses are reduced, as you can see, 41%. Hippocampal doses, 62%. This is a young man, a working person who works in the Merchant Navy. Of course, his cognitive ability is very, very important. And similarly, we find that with proton therapy, when we compare with IMRT, the parotid dose, the oral cavity dose, and the midline mucosa dose are reduced anywhere between 25 to nearly 35-40%. And what is the importance of that? When you reduce the dose to the midline mucosa, the ability of this patient to undergo CCRT after having received neoadjuvant chemotherapy is improved. I come now to oropharyngeal cancer. I see that I have only 3.5 minutes left, so I will skip straight away to this MD Anderson randomized trial that has been published, that is presented by Dr. Stephen Frank. This is comparing 440 patients. 221 have received IMPT, 219 have received IMRT, and what we find is that there is a significant survival advantage in patients receiving proton therapy. So this is the overall survival, and as you can see, the p-value is 0.045. And patients who undergo proton therapy live longer. Patients who undergo proton therapy have a smaller chance of requiring a gastrostomy tube. The recently presented torpedo trial created a lot of excitement because there was some doubt about whether protons will actually add value in oropharyngeal cancers. And as you can see here, though it was called a negative trial, we can see that at the end of treatment, as well as at 3 months after treatment, patients who have received proton therapy have much better swallowing function, something that is very, very valuable, I think, for patients, which was not actually a part of one of the endpoints of the study. I'll finally come to our work in oral cancer. Of course, for all of us in South Asia, oral cancers are very important. It is our most important or most common cancer amongst men. We have created a protocol. This is work that has been done by my team at the Proton Center. Proton therapy for reducing oral mucosal doses and reducing the possibility of oral mucositis. What you see in the graph out there is the dose that is received to the oral mucosa in proton therapy is marked in blue, and the dose that is received in photon therapy for the same group of patients is marked in red. And as you can see, there is a 40% to 60% reduction in the dose that is being delivered to the mucosa outside the target. The end result of that is superbly preserved mucosa as compared to the green labeled pictures that you see, which are patients undergoing IMRT for treatments for tongue cancer, vis-a-vis the mucosa in patients who have been treated with proton therapy. Naturally, this has a big advantage in terms of narcotic reduction, also in taste, also in their ability to be able to have chilies at some point of time, have spicy food at some point of time. So this is what it looks like. The extra dose that does not go to the mucosa in patients who receive proton therapy. This is what it looks like. And this is finally our work which is under preparation, which we are submitting shortly. Again, this is a propensity matched cohort, 53 patients of oral cavity tumors and oropharyngeal tumors. So what you're seeing here is the doses being received by the entire cohort: spared oral mucosa, spared pharyngeal constrictors, spared larynx, spared parotid, and the spinal cord, not spared parotid, sorry, parotid contralateral, larynx, cochlea, very important in patients undergoing cisplatin chemotherapy, and mandible. As you can see, this is dose de-escalation to the OARs. Now, the question that is naturally will be asked is this dose de-escalation coming at some cost in terms of control or survival? And this has actually been a very gratifying part of our analysis of this group of 53 patients, is that our local regional control as well as our overall survival are significantly in favor of proton therapy. So in conclusion, I would like to say that there is evidence to support the role of proton therapy in improving local control, survival outcomes, and reducing toxicity. I did not go over the studies that have been, the phase 2 studies that have been published from MD Anderson, Mayo Clinic, and Memorial Sloan Kettering, which talk about how the quality of life of patients undergoing proton therapy is better. There is also a Taiwanese data which tells us that the overall survival from their National Cancer Database, which also suggests that it's not just toxicity reduction, but actually an improvement in the overall survival, something that should actually enthuse head neck oncologists, because this is really after a long time that we are talking about any activity which improves the survival in head and neck cancer patients. And what I believe is really the barrier to its application is access. And it is access, the availability of larger number of proton therapy units, for example, like Spain, which is going to acquire 10 units, or I understand in China there is going to be widespread installation of proton therapy machines. So basically it is access which will enhance acceptability and impact. I would like to take this opportunity to acknowledge my team as well as the team at the Apollo Proton Cancer Center. As you know, this is the first proton therapy center in this part of the world. We have now treated more than 2,000 patients from about more than 30 countries, and head and neck constitutes about 20% of the work that we do at the Proton Center. Thank you very much for your attention.